Let's review now section 4, CNS drugs. As we approach CNS drugs, you could think of them in two broad categories. The CNS depressants, the ones we'll start reviewing, and then the drugs that cause CNS stimulations. In the CNS depressants, we'll look at drugs that work through major inhibitory neurotransmitters such as GABA, but we'll also look at drugs that work by various ways to interfere with electrical activity in the CNS and depress it, such as anticonvulsants, anesthetics. Otherwise, another major mode of CNS depression will be with opiates. As far as CNS stimulation, looking at the dopamine system will be quite relevant to see some effect of stimulation when dopamine is associated with psychosis, or where dopamine antagonists therefore will be antipsychotic. And of course the groups of antidepressant will close our CNS review. Well, in chapter 1, we'll review sedative, hypnotic, and anxiolytic drugs, or if you want, over the next two chapters really, we'll look at drugs that interfere with GABA, the major inhibitory neurotransmitter in the mammalian brain. When we look at sedative, hypnotic, anxiolytic drugs, we're looking at three types of chemicals. The family of benzodiazepines, BZs in our syllabus, all of the barbiturates, but also alcohols. Alcohols will be a part of the short chapter 2 in this section. Before we go into too much details of mechanism, the first diagram, entitled CNS effects associated with increasing doses of sedative hypnotic drugs, tells us some key points that will differentiate particularly benzodiazepines from barbiturates, and if you want to add to your book, alcohols. You see, this diagram plots, as a function of the dose of these chemicals, on the y-axis, the CNS depressant effect. Now let's look at effects of CNS depression. And let's first notice that the initial CNS depressant effect is that of paradoxical disinhibition. What we mean by this is that effectively the human cortex is filled with excitatory amino acid transmitters, particularly glutamate and aspartate. And our cortical areas are constantly under negative inhibitory influences of subcortical gray matter. Now, in the subcortical gray matter is where we find tons and tons of GABA-containing neurons. And often, the first place to see a strong inhibition is in those subcortical nuclei. As a result, we are really inhibiting the inhibitory tone that normally tempers down our cortical activity. This is why the initial doses of CNS depressant may paradoxically present with excitation. I'm sure most of you watching this tape have had some encounters with alcohol, or at least with people who might have drunk alcohol. When people drink alcohol, you know that often at small doses, people will start being fairly excited. They may start talking more than they wanted, maybe even do things that they would have never imagined they could have, often being sorry about it later on. Well, this is the paradoxical disinhibition we're talking about. And this can commonly occur also with benzodiazepines and barbiturates. This is why, although they're called CNS depressants, you shouldn't be surprised that some individual will respond with agitation, restlessness when they take those medications. Now, normally, if you look in the diagram, the next planes of CNS depression would involve, as we often used as a side effect, at the very least, sedation, drowsiness. It is also at this level of CNS depression that we tend to start seeing an effect on cognitive function and particularly on anxiety. Anxiolysis requires, therefore, minimum CNS depressant activity from a drug. Potentially, this level of CNS depression may also have anticonvulsant and muscle-relaxing activity. It is this level of CNS depression that is generally looked for when we use benzodiazepines or barbiturates in ambulatory patients. Now, as you increase the dose further, the next level of CNS depression is that of hypnosis and eventually anesthesia. Once we get to levels of anesthesia, the critical issue is, can the patient still have vital functions working properly, Or should the patient now be actually intubated to breathe? Well, you know, the answer to this is from the anesthesia onwards, respiratory tone, respiratory control gets tremendously depressed. So does vasomotor control, to the extent that a little bit more of a CNS depressant may cause medullary depression with coma and death. Look at the key difference existing between barbiturates, alcohol also, versus benzos. Benzodiazepines tend to plateau in their CNS depressant activity, essentially telling you that there is only but so much CNS depressant activity you can achieve with a benzodiazepine drug. Contrast, a barbiturate is absolutely dose related when it comes to the level of CNS depression. You could take barbiturates by themselves, and if you take a big enough dose, end up in coma, respiratory depression, and death. It should not be the case with a benzodiazepine. In turn, this indicates to us that the therapeutic index, the safety in using larger doses of a drug, well, is going to be much greater for benzodiazepines than barbiturates. And you know well that since the 1970s, benzodiazepines have really supplanted the use of barbiturates when it comes to treat problems such as insomnia or anxiety. The thing that we'll have to explain is how come drugs that interfere with the same neurotransmitter GABA and the same target, a GABA A receptor, manage to have such a different pharmacology. Well, for this, let's examine what a GABA A receptor looks like. If you look at the diagram entitled Site of Action of Drugs on the GABA A Complex, what you're looking at here is the classical appearance of an ion channels that would be ligand-gated. You know already from the general principles what a G-protein linked receptor looks like. It looks like a receptor with 7 transmembrane domains. Well, now have an idea of how to schematize, how to draw a ligand-gated ion channel. A ligand-gated ion channel is made of 5 subunits. The 5 circles on your diagram. These 5 subunits are sometimes well established, in other cases, such as for GABA receptors, not well known. For GABA receptors, 3 of these subunits are given Greek letters, alpha, beta, and gamma. Ligand-gated ion channels are made of 5 subunits, therefore are pentameric in structure, and the 5 subunits organize themselves in the cell membrane in a manner to form a pore. Now the pore is the actual channel, and the channel generally has selectivity for a specific ion. For the GABA A receptor, the ion selectivity is to chloride. Now chloride being negatively charged and net force on chloride being such in the CNS that chloride would go into the cell, the net entry of negative charges causes hyperpolarization of neurons. This hyperpolarization brings those neurons farther away from threshold, and therefore render them less excitable. Now, GABA is our major neurotransmitter. It is considered that literally upwards of 2/3 of the neurons we have in our brains actually contain GABA. Now, if this is a GABA A complex, you would have to know a little bit about other GABA receptors. Really, there's also GABA Bs and GABA C receptors. A GABA B receptor will be important for a drug we call baclofen, which is used in spasticity that we'll see later on in the anesthesia chapter. But a GABA B receptor is also linked to a channel. A GABA B receptor, though, does it through G-protein coupling, therefore it's the phosphorylation, dephosphorylation reactions that may open or close that channel. Nonetheless, being that it's a potassium channel, when a GABA B receptor is activated, the potassium efflux also results in hyperpolarization of cells. Benzodiazepines, barbiturates, and alcohol interfere with the GABA A molecule. Let's look back at that same diagram. When we look at the 5 subunits indicated in the diagram, the fact that GABA, the endogenous neurotransmitter, binds to the alpha subunit. As a matter of fact, the rule of thumb is that the alpha subunit of ligand-gated channel is generally the unit that binds to the endogenous neurotransmitter. Notice then that benzodiazepines and barbiturate do not bind at the same spot as GABA does, essentially telling you they bind allosterically. Allosteric binding, allosteric simply meaning allo for other, steric site. Now, the fact that they bind to another site is going to be at the basis of their different effects on GABA activity. Be aware that benzodiazepines need the gamma subunit of GABA receptors to do their jobs. Barbiturates need the beta subunit to do their jobs. And interestingly, there is no overlap in the binding sites to a benzodiazepine or the binding site to a barbiturate. They cannot compete for each other for binding. By the same token, if there were antagonists to these binding sites, they would be very selective to either benzos or barbiturates. We will further distinguish for benzodiazepine binding sites two spots on the GABA A receptors, and these spots where benzodiazepines bind to are given kind of very loosely the term of benzodiazepine receptors. Now, never think that benzodiazepine receptors are unrelated to a GABA A receptor. In reality, a benzodiazepine receptor is simply a site involving the gamma subunit to which benzodiazepines bind to. Well, to summarize this in text now, you see described to you on this slide the GABA A receptor activation increasing chloride influx, therefore resulting in hyperpolarization, against the GABA B activation resulting in potassium efflux, which also results in hyperpolarization and depression of neurons. Both mechanisms result in membrane hyperpolarization, but let's focus more now on a benzodiazepine and its interaction with the GABA A receptor. Benzodiazepines are said to potentiate GABA. If you look a little bit at the whiteboard 1 second, let me remind you, as far as the general principles are concerned, what potentiation is all about. Now, you remember we look at potentiation or antagonism on what we call log-dose response curves. So imagine the following curve, where on the x-axis we putting GABA, and on the y-axis we putting a response to GABA, such as the percent CNS depression, if you want. In doing so, we can show a control curve, which would have a sigmoid appearance, which would represent endogenous GABA with, as you increase its dose, more and more CNS depression. Potentiation, if you remember well, is a shift to the left of this curve. So if you remember your general principles, when there is potentiation of the response to an agonist, such as GABA, we see an overall shift to the left of the curve, such as now it would require less GABA on the red curve in order to reach the same amount of CNS depression. This is what we call potentiation. But you know, to really stress this further, I would give it to you as a mathematical correlate. In reality, if I give the efficacy of a benzodiazepine has an efficacy of 0. So you're going to think, wait a minute, is it a blocker? No, it's not a blocker. But what happens is that if I add my benzodiazepine to GABA, and GABA is a full agonist, GABA is a full agonist. If I add it to the benzodiazepine, it has an efficacy of +1. Well, the net result of combining the two together would be an effect of +2, which of course is always very rewarding to us who were really miserable in mathematics, meaning that we were absolutely correct when we said long ago that 0 + 1 = 2. That's beside the point. The idea is this is the mathematical model of potentiation. Benzodiazepines alone have really no effect of their own, but in presence of GABA, they increase the amount of response. Therefore, they potentiate. It's as if you needed less of GABA to reach the same response. So it's as if GABA had more potency. Now, keep in mind the key point here. A benzo alone really does not open the ion channel for chloride. It requires the presence of GABA to do its job. This is why, if you look back at your text, when we say benzodiazepines potentiate GABA, what they achieve is allow GABA to bind more often. As a result, they are said to increase the frequency of chloride channel opening. In reality, as mentioned here, they really have no GABA mimetic activity of their own. telling you a benzodiazepine binding to a GABA-A receptor is not going to open the receptor to let chloride get in. It will simply allow GABA to bind more often to its site. Now, benzodiazepines are said to act through benzodiazepine receptors. Remember that these receptors are part of the GABA-A complex, and we can distinguish two subtypes of binding sites. They're referred to as BZ1 and BZ2. A BZ1 receptor mediates sedation. A BZ2 receptor mediates anti-anxiety and also impairment of cognitive functions. Now, relevance of knowing that there are two binding sites with different neurophysiology attached to them. Imagine that we wanted to develop drugs that would only be used for the treatment of insomnia, therefore mediate sedation only, and have no effect such as cognitive impairment. Then it would be relevant to try and develop drugs that would recognize BZ1 over BZ2. We'll see that this has been done. Of course, this is why this is relevant on your exam. Let's contrast barbiturates to benzodiazepines. Notice that barbiturates are said to prolong GABA activity. That is, they increase the duration of chloride channel opening. You see, unlike benzodiazepines that were helping GABA bind more often, barbiturates allow GABA to stay on the channel for longer. And even more relevantly, at high doses, they have GABA mimetic activity. Understand by this, barbiturates, unlike benzodiazepine, can open the GABA-A receptor by themselves. Since we have many more receptors than are required for a GABA response, a safety issue that we have with all receptors, which are known as spare receptors in pharmacology, we could imagine doses of barbiturates that may result in hyperpolarization that are far beyond what physio would have expected. Hence the potential life-threatening CNS depression at high doses of a barbiturate. Now, barbiturates do not act through benzodiazepine receptors. They bind their own sites on the GABA-A complex. But of relevance also to their toxicity is the last statement on that page that you want to underline. If you have reviewed your biochemistry, you will remember that barbiturates also inhibit complex 1 of electron transport chain. This adds on a level of toxicity that is not shared by benzodiazepines. If you block a complex 1 of electron transport chain, you also interfere with ATP synthesis in neurons. As a result, you now have a drug that can by itself cause hyperpolarization because it's GABA mimetic, but that also deprives neurons from ATP to cause really extreme CNS depression. In your margin is a very important clinical correlate. If you have your red pen handy, make sure you underline it. We hear very often as a feedback that flumazenil is being board tested. Flumazenil is a benzodiazepine receptor antagonist. So if you have CNS depression to a benzodiazepine, such as you would have in overdose, or such as you would have when you use IV benzos, for instance in anesthesia, to reverse the CNS depressant effect, you could use flumazenil. The point your boards are after, which makes most sense in basic pharmacology, is the fact that flumazenil will not reverse the CNS depression of barbiturates or alcohols. Of course, why do you think this is the case? Well, you know, the general principle that is hit here one more time is the fact that antagonists have zero efficacy. An antagonist does not really, quote-unquote, reverse anything. What it does is block the action of an agonist. And being that benzos, barbiturates, and alcohols do not share the same binding site, blocking a benzodiazepine binding site only reverses benzodiazepines responses, not barbiturates, not alcohols. By the way, there are no known antagonists to barbiturates or ethanol binding on the GABA-A channel. Just flumazenil for benzodiazepine binding sites. And a final point, flumazenil antagonizes as well BZ1 binding as it does BZ2 binding. It's a non-selective antagonist of benzodiazepine receptors. You have a table that shows you various benzodiazepines and their main uses. Now, overall, at a mild CNS depressant level, benzodiazepines are used for three major reasons. They're used in anxiety, they're used in insomnia, and they're used as anticonvulsants. Other more specialized reasons to use them? Well, often IV in hospitals, they could be used in situations with seizures, particularly status epilepticus. Don't forget otherwise that any CNS depressant might be used in hospital as part of the cocktail of drugs we use in anesthesia, and we'll cover anesthesia in a subsequent chapter. So if we look at the various benzos in this table, they are easy to recognize. The names are either in azolam or azepam. The issue is how different are they from one another? Well, the answer there is fairly simple. The only differences are really in pharmacokinetic. It's really the time they last, their half-life, their way of being administered, maybe the color of the pill, the shape of the box. These are the type of differences we're talking about. Since overall, any benzo can be used for anxiety, for insomnia, for sedation, therefore to induce sedation, or also could be used as anticonvulsant. What could rule one use over another? Often the half-life. Imagine you wanted to treat anxiety in a patient. You would like to have a chronic dosing and a constant presence of the drug to fight the anxiety. Well, this is why you want long duration of action benzos for anxiety, such as the drug alprazolam. Alprazolam has as one of its major trade names Xanax, and you know that this is one of the most commonly prescribed drugs for anxiety, for panic attacks, for phobias. Diazepam, lorazepam, and midazolam are to put in the same bag in that they exist as IV preparation. Because they exist as IV preparation, besides being used for anxiety, they can be used in hospitals. And they're used in hospitals for preoperative sedation, for muscle relaxation, and certainly in withdrawal states associated with seizures. Indeed, diazepam, lorazepam can be used for status epilepticus. Otherwise, midazolam, being so short-acting, can be used for anesthesia to induce anesthesia itself. All three drugs will share the fact that when used IV, they cause a certain degree of anterograde amnesia. And this anterograde amnesia is relevant in preoperative sedation. We'll talk more about it in the anesthesia chapters, since like this it affords a patient that will not remember some of the key issues going on in emergency or operating room. Contrast benzos used in sleep disorders, temazepam and oxazepam. Those are benzodiazepines that are short-acting. Short-acting is what is required here, since you don't want to take your benzo in the evening and go to sleep and never wake up the next morning. You want a drug, therefore, that is short-acting. Depending on the type of insomnia, you may want a preparation that acts immediately upon going to bed, or that might work 2 or 3 hours down the road, since some people have midnight insomnias or at bedtime insomnia and so forth. Temazepam is classically used for sleep disorders. A few words of pharmacokinetics of benzodiazepines. As CNS drugs go, all CNS drugs are liver metabolized. Since they require lipid solubility to cross the blood-brain barrier, they will require a liver in order to be rendered more water-soluble for excretion. A key point of benzos is the fact that they are metabolized to active compounds. Now, there are notable exceptions to this. The drugs oxazepam, temazepam, and lorazepam. These are drugs that are actually metabolized out of the liver and that are purely conjugated and then excreted. A relevance of active compounds. Imagine I told you that diazepam has a half-life of 4 to 5 hours. Then you would expect diazepam to be in the body at significant concentration for at best 4 to 5 half-lives. But you see, then duration of action should be fairly short. Yet, surprise, you give diazepam and you get CNS depression for sometimes a day and a half, and people feel hangovers from diazepam. This simply comes from the metabolism to active metabolites. The active metabolite will prolong the duration of action of most benzos, except which ones? Well, you would have to answer or choose in your question oxazepam or temazepam or lorazepam, the three benzos that do not give active metabolites. Those variable half-lives and duration of action give rise to the little categorization we give you here. Midazolam is by far the shortest acting, only used pretty much in hospitals IV. As far as oxazepam and temazepam, since they're fairly short-acting, they're used for insomnia, as we saw, whereas longer-acting drugs are used for anxiety. Don't forget the fact that lorazepam and diazepam also exist in IV forms and can be used in hospital. How about the uses of barbiturates? Barbiturates, theoretically, could be used for exactly the same indications as benzodiazepines. Because of their important CNS depressant toxicity, pretty much their uses are now very small, and we will only mention two drugs of broad relevance: phenobarbital, which is long-acting and is used for seizures, particularly to treat seizures during pregnancy, as we'll see in Chapter 3, but also in febrile seizures, such as you see in children. And thiopental is extremely lipid-soluble, since it has sulfur in its structure, and is ultra short-acting. This is one that is used purely IV to induce anesthesia. Barbiturates are, of course, also liver metabolized and sometimes to active compounds, but really their relevance for your board question is point numbers 2 and 3. They are general inducers of cytochrome P450s. We know that most questions that love to deal with drug interaction by induction deal with a barbiturate in the stem, although you must remember some other drugs. Do you? I hope you're thinking about phenytoin, carbamazepine, rifampin, chronic alcoholisms. All those were as many possibilities of induction of P450s were explored in the general principles. When drugs are inducers of P450, they are forcefully contraindicated in the rare event that a patient has a porphyria, particularly when people have acute intermittent porphyria, which is sometimes diagnosed because of the mishap of using a general inducer such as a barbiturate. If you remember well, porphyrias are genetic disorders where there is an enzyme deficiency in the heme synthetic pathways. And cytochrome P450s in turn are enzymes that require a heme group. When a drug induces cytochrome P450, a drug must also induce heme synthesis to make functional enzymes. Well, if it induces heme synthesis, it will cause a buildup of porphyrines, the intermediates of heme synthetic pathway that accumulate in porphyrias. Therefore, any inducer, barbiturates in particular, are contraindicated in porphyrias. Final aspect of looking at CNS drugs, and here at GABA drugs. Any CNS drug, because of the fact that it goes in our brain, can potentially change the way we feel. And some people love certain feelings. Well, some people get a kick out of CNS depression. We're not quite sure why. But individuals who love CNS depressant are also often individuals who love alcohol. Realize further that alcohol is not only a CNS depressant, it shares some pharmacology with benzodiazepines and barbiturates. All this means that it is very relevant to have an idea of the abuse liability of benzodiazepines and barbiturates, particularly knowing that there is cross-tolerance between alcohol and those compounds. Are benzodiazepines and barbiturates equally liable to abuse? Well, the answer is no. Really, the ones that are more likely to be abused are the barbiturates. After all, they're the ones that are as strong a CNS depressant as alcohol is. Benzodiazepines do not have as strong an abuse liability as barbs do, but they still do. How do we know about the abuse? By looking at tolerance and dependence to these drugs. We know that chronic use leads to tolerance, and the tolerance to the effects of benzos and barbiturates require the patients to seek and take more drugs. There is cross-tolerance between benzos, barbs, and alcohol to the extent that clinically, a chronic alcoholic will require doses of benzos and barbiturates that might have killed someone who is not chronic alcoholic. The type of dependence that is seen is both psychologic and physical. Psychologic dependence is established when upon withdrawal craving occurs. Craving to benzos, barbiturates, and alcohol is very strong, pushing the patient to look for more drug. On the other hand, the physical dependence is established when upon withdrawal there are physical symptoms, in other words, a syndrome that we call withdrawal. Although the abuse liability of benzos is less than that of ethanol and barbiturate, it is real. And as we look at withdrawal signs of benzodiazepines, we notice that, as expected, withdrawal will be a rebound effect. Imagine if benzos have been used chronically and benzos enhance inhibitory tone in the brain. The brain had plastic adaptation whereby it tried to enhance its excitatory and stimulatory tone. If you were suddenly removing the benzodiazepine, you would now be facing a brain that has excessive excitatory ability. As a result, you see CNS stimulation to the withdrawal of a CNS depressant. Well, the CNS stimulation to benzodiazepine is generally simply rebound insomnia and rebound anxiety. Normally, it should not be associated with the ultimate stimulation, which are seizures. Seizures are only seen when benzodiazepines were actually used as anti-epileptic or were used in such high doses that they were causing significant CNS depression. You know, high doses such as the one that maybe an abuser would have. So for a patient who takes therapeutically benzodiazepine, more often than not, withdrawal signs remain at the level of insomnia and anxiety, which are not life-threatening. You will contrast this to withdrawal signs of barbiturates and ethanol, since those compounds are much more powerful CNS depressants. Their withdrawal is characterized not only by anxiety and agitation, but also by life-threatening seizures. They are referred to as DTs with alcohol. Those life-threatening seizures, status epilepticus, require immediate attention in a hospital, and the management of withdrawal is to place the patient back under CNS depression. It is a supportive management that involves particularly the use of IV benzodiazepine, such as lorazepam or diazepam in particular, to curtail the status epilepticus. As a matter of fact, as drugs of abuse go, only barbiturates and alcohol truly have a life-threatening withdrawal with seizures. Drugs of abuse such as cocaine, amphetamine, heroin, cannabis, hallucinogens are devoid of life-threatening withdrawal. We will do a section at the very end of CNS drugs that will deal with a quick review of all drugs of abuse. How about drug interactions? Well, you know, if you use a CNS depressant, imagine what would happen if you were adding on another CNS depressant. Then you would have an additive CNS depression effect. Classic issue. A patient takes benzodiazepines very carefully at therapeutic levels. That patient happens to travel and catch a cold on the plane. The patient goes to a supermarket or a Rite Aid or wherever you want and gets some cold medication that contain antihistamines. Those antihistamines are CNS depressant. Now you're adding the antihistamine to the benzo. And then on top of this, during that maybe business travel or fun travel, well, the patient goes out to a restaurant and starts socially drinking, not abusing alcohol, just drinking a glass of alcohol. By the time you have the glass of alcohol, the cold medication, and the benzodiazepine, insomnia is the least of your problem. You might very well be sleeping for the rest of your life. There is always additive CNS depressant effect between drugs. And keep in mind, this can lead to possibly life-threatening respiratory depression, even with therapeutic concentration of each individual compound. So let's give a list. Well, you know, anesthetics, of course, are CNS depressant. But don't forget antihistamines, which are over the counter. All the opiates as pain medication. Drugs that have beta blockade activity like propranolol, which might have been prescribed for hypertension without any thought as to being CNS depressant. Alpha-2 agonist, antimuscarinic medication. All those are just as many drugs that would add on to the CNS depressant effect of benzos or barbiturate. Otherwise, for drug interaction, let's remind ourselves one last time how barbiturates induce metabolism of pretty much any drug that is liver metabolized, such as oral contraceptives, decreasing their efficacy, but also major drugs such as carbamazepine, phenytoin, anticonvulsants may be causing an issue with decreased efficacy, but also important drugs such as warfarin, anticoagulant. If you induce its metabolism, you could get bleeding. And my favorite drug of all, ETC, etc., since obviously the list of drugs just extends to as many drugs you could come up with, which are lipid-soluble and liver metabolized. To finish this chapter 1 on sedative hypnotic anxiolytic drugs, well, there are drugs other than benzodiazepines or barbiturates that may either be used for sedation or that may be used for anxiolysis. Non-benzodiazepine drugs include zolpidem and zaleplon, the famous Z drug. And those Z drugs are BZ1 receptor agonists. Now notice, they're not benzodiazepine. In other words, they don't share the structure of benzodiazepine. But nonetheless, they bind to the BZ1 receptors, or if you want, the benzodiazepine binding site that mediated sedation on the GABA-A receptor. The advantage of those two drugs to have less effect on cognitive function, which tend to be BZ2 mediated, particularly have not such an issue with problems such as anterograde amnesia, cognitive dysfunction like impaired learning, impaired feeling, and so forth. Because they're benzodiazepine agonists, they are reversed by flumazenil, in spite of the fact that they're not benzodiazepines. They're purely used in sleep disorders and are associated with less tolerance and abuse liability than benzodiazepines themselves. How about for anxiety? Well, for treating anxiety as a non-benzodiazepine drug, the famous drug buspirone. The bold question to buspirone has often been the fact that it simply has no effect on GABA. It does not work on GABA neurotransmitters, it works on serotonin. And buspirone is an important drug in its mode of action. It is a 5-HT1A partial agonist. If you have watched the tapes for the general principles, you know that this is an example I like to take when we review partial agonists, since we can well understand how buspirone is an important drug for generalized anxiety disorders in that it may increase serotonin neurotransmission, but it may also block it. The relevance of this being that the drug really modulates serotonin neurotransmission. When there is excess serotonin and anxiety and panic, the drug behaves as a blocker, but never blocking to the extent of causing CNS depression. Vice versa, when there is CNS depression and feeling down, well, the drug can behave literally as a mild antidepressant. Of course, it means that if you use this drug as an anxiolytic, it will be devoid of sedative side effect. This is important, that lack of sedative side effect, since benzos, when they're used for anxiety, will make you feel sleepy. Here you have an anxiolytic that is non-sedative. A strange story is how long it takes to really have effect. It takes 1 to 2 weeks for having an effect, and in a way that is very reminiscent of the way antidepressants work. It's probably an issue that has to do with plasticity of neurons and changes in sensitivity or numbers of serotonin receptors. The fact that it takes 1 to 2 weeks for effect means that it is not unusual for people to first be placed on a benzodiazepine as they're going to take buspirone, so that like this they have an acute effect at least for those first couple weeks before buspirone would kick in. Now, if you look at the rest of your syllabus, you would see that other sedative preparation might be found over the counter. Generally, they're antihistamines. Antihistamines cause sedation because of antimuscarinic effect. Otherwise, for strong sedation, never forget opiates, which after all can even be used during anesthesia since they're sedative. Certain antipsychotics, antidepressants may have also strong sedative effect, generally related to the antimuscarinic pharmacology. Well, this closes.